Good morning, everyone. I wish you a warm welcome to this plenary session, which is called Living in a World with Pandemics. I'm glad to see people live here, because after 2 years of pandemics and lockdowns, it's great that we can see each other again and have some small talk as well. I'm Mariette Veldkamp. I'm an associate professor of medical virology in the Leiden University Medical Center, and I will moderate this session. And in the next 75 minutes, we will discuss living with pandemics, obviously, but then from a scientist view. And we will learn what it takes to translate scientific findings into useful strategic advice to policymakers and, at the end, to the community. And especially we are experienced in that regard because of the last 2 years, when we were confronted with the coronavirus pandemic. For this purpose, we invited 5 speakers for you. They all played an essential role in their countries or in their organization, providing us with scientific advice how to cope with the coronavirus pandemic. I will start introducing them and ask them to come forward to the podium. First of all, Jaap van Dissel. He is the director of the Netherlands Infectious Disease, the Netherlands Center of Infectious Disease Control and professor of internal medicine at Leiden University Medical Center. Then we have Salim Abdul Karim. He's a clinical infectious diseases epidemiologist and a global health professor in the Department of Epidemiology at the Mailman School of Public Health at Columbia University in New York. Then we have Petter Brodin. He's a Garfield West Chair and Professor of Pediatric Immunology at Imperial College London. The fourth speaker is Mark van Ranst, Public Health Doctor and Professor of Virology at the Catholic University Leuven in Belgium and at the Rega Institute for Medical Research at Leuven. And last speaker is joining us online. It's Nicole Grobert. I have not seen her, but I'm sure she must be somewhere. She's a professor of nanomaterials at Oxford University in the UK, but moreover, she's Chief Scientific Officer of Research and Innovation at the EU Commission. To set the stage for the discussions, we asked the speakers to prepare a short talk and provide us with some information that could serve as a basis for the further discussions. And I would like to ask Jaap van Dissel to start off with his presentation.
Okay. Yeah. Okay, thank you, Mariette, and thank you for the opportunity to speak at this conference. The main talk is preparedness for infectious disease outbreaks. I will focus on the Netherlands and show you some examples how we dealt with the corona outbreak. Obviously, the corona pandemic hit different countries at varying intensities, and countries had to prepare and were presented with unprecedented challenges during the outbreak. And just to name a few, in the Netherlands, the characteristics of the country, if it's a hub or not, like the Netherlands, it's really a hub to Europe. The population density is obviously a very important aspect of a disease that goes by contact. And the consequences for the corona, in the corona outbreak were mainly related to the age and underlying diseases. And as pictured in the slide, the Netherlands has really a lot of more elderly people, so is at risk of an outbreak with a lot of consequences. And obviously this differed between countries and differed in Europe. Well, when you speak about outbreak control, you speak about pandemic preparedness, you speak about crisis management, and obviously the third aspect is the recovery phase. I will mainly focus on the crisis management. And just give you an example how the Dutch went forward during this outbreak. So first of all, you have to have the vision that science, this is a scientific congress, so science really should have an influence on policy making, and this should be in contact and should be consistent. From this vision, you have a strategy that is more or less the same in the whole of Europe, which was to minimize the consequences of the transmission and the circulation of the virus. And of course, the main differences are where you balance the individual freedom versus the security of the society. You have to make trade-offs by restricting personal freedoms to make society safe. And of course, this is the main political stage. Well, specifically prevent and combat outbreaks, and of course the point on the horizon was vaccination and the establishment of immunity, if possible, herd immunity, but that at the start was really a point on the horizon. So this was translated into specific goals, and this translation was done in, obviously in collaboration with the government and the cabinet. First, protect the vulnerable, which basically are the elderly and underlying disease persons. Keep the hospitals and the ICU units intact. In the Netherlands, this became a big issue because we've been very keen to keep the number of beds low. And for instance, when you compare the number of beds in the Netherlands with the situation in Belgium or with France, it's about 1 to 4 to 5. So in the Netherlands, we really didn't have much of an ability to use more beds. And of course, that's also related to the number of healthcare persons. And finally, you want to keep an eye on the virus so you can present scenarios to the government, make prediction how it will go. And for these surveillance and early warning measures, we had several types of interventions and ways to look at it, and they're all listed here. I just want to draw your attention to the second one in the surveillance group, which is the sewage surveillance that we started in the Netherlands. And at the moment we are taking 3 samples a day from every sewage collection point, which are 350 in the Netherlands. There we can determine the number of viral particles, and this really correlates with the number of infections in society. And of course, sewage cannot be influenced by, or at least only to a small degree, by behavior, by health-seeking behavior. So really, it's a very objective way of looking at the outbreak at the moment. And of course, we also have different test abilities, but then not everyone goes to be tested. In the Netherlands, it's about 50%, 50 to 60%. So 40% have complaints, but do not test. And of course, in the sewage surveillance, all people are taken up. So how was the response in the Netherlands organized? Well, we have a system in place for already 15 years, which we call the Outbreak Management Team, which is basically a self-organization of medical scientists and epidemiologists. So it's only medical, that's important maybe for the discussion later on. This Outbreak Management Team considers all the scientific evidence, but also, of course, experience from practice, makes a synthesis of knowledge, and the synthesis is connected with a practical advice. Then there is an administrative evaluation, whether or not the advices are possible or not, or perhaps cost too much money, or are not feasible. Think of school closing. They little bit convert the scientific advice to be presented to the Minister of Health and the Prime Minister. They take the political decision what to follow and what not to follow. And usually we present the advice in different scenarios, scenarios with different consequences for the number of cases and the spread of the virus. And then a decision is made and a decision is implemented. The advices of the Outbreak Management Team in the Netherlands are public. They are presented to the press, to the media, but of course first to the parliament. And usually there is a briefing in the parliament concerning the advices, which is also televised and followed by press conferences. So there are various ways to make sure that the scientific advice is presented to the public separately from the political decision. Of course, this sounds simple, and perhaps it is simple, but it tends to become much more complex quite quickly. Here you see, partly in Dutch, but it's not really necessary to read every line, but it's just to show you that in the end, of course, there are multiple departments of the cabinet involved. For instance, the science department, the education department, economic affairs, they all have to collaborate and work together, and you really need fit and purpose structure and mandates to make this work. And it also depends very much on the willingness of the leadership, of course, to collaborate, because it's very easy to obstruct the process. But in the end, there was a quite strict way of making decisions, which started with the civil servants and with the scientists, then was presented to the cabinet. They make the decision. In the Netherlands, we have a special way of enforcing and communicating the decisions to the public and to the so-called security areas, which are basically collections of mayors that can execute the interventions in their municipalities. And then, of course, we also have the strong view from the hospitals. There's a system to exchange patients between hospitals, which became quite important to ensure that every region was able to admit the necessary patients. And finally, specifically for corona, we had several consortia formed, for instance, looking at the availability of personal protective measures, looking for the availability of test capacity, spreading the patients, all things like that were specifically initiated for corona. So how does it work? Because in my talk, I just want to highlight that there are large cultural differences between politicians and scientists. And when you present the politicians with scientific evidence or scientific knowledge, it's a different culture that starts working with that. So first of all, as scientists, we are committed to finding the truth, so to say, by facts. And they are based during the corona initially on more practice than evidence, but of course a lot of studies were done in time. So science goes from evidence-based but also experience-based. And of course, as scientists, we're always doubting what is the case. So there are many ifs and buts. And we are professional doubters. And of course, the politicians are quite different. They have to be decisive. In times of crisis, they have to look stern and make decisive decisions, firm statements, if possible, one-liners. And where scientists are empiric, of course, the politicians are normative. They have to weigh the different values and go for consensus, whereas we go for evidence-based facts. And that's quite different because, first of all, if you change an opinion as a scientist, it's progress. And if you do the same as a politician, it means that you probably get less votes next time. So there is quite a difference between these two cultures. In science, you try to, in the end, get one opinion and different scenarios with different consequences. And you would like to expand the scope that you offer to politicians so they can make informed choices. Of course, politicians work quite differently. They like differences because differences are made more distinctive and distinct them between each other. And if the government, for instance, takes over the scientific advices without much consideration, that will in the end lead to a situation that the scientific advice will just be considered an opinion because the politicians by nature try to make different opinions to be distinctive among each other. So in the interaction between scientists and politicians and reaching a way to get the interventions right in a pandemic. It's very much about roles that need to be defined, about boundaries that need to be established and kept, and certainly also culture. And this, of course, is also a big point in the evaluation of the outbreak, as you can imagine. Well, finally, in the end, it's very much about culture and behavior of the public. And in the Netherlands, of course, we are a country which is at least half under sea level. So they say that God created the earth and the heavens, and the Dutch created the Netherlands. But you just wonder whether the ability of the Dutch to build dikes and to control nature in the sense of water is really also reflected in the Dutch mentality. We love planning, we love to make strict order in our country, and of course this is not always possible. Nature is always taking its own view, and it's difficult to manufacture nature. So I guess in the end we all want to go for a resilience and a flexible approach, but I don't think we are there at the moment. And this is my contribution. Thank you.
Thank you for a very clear talk and explaining the relation between science and politics. I ask the second speaker, which is Salim Abdul Karim. And in the meantime, I'd like to add that you can ask questions by using the Slido question mode and use the QR code that you all received.
Thank you very much. It's a great pleasure and an honor to be with you here today at ISOF. I will be talking about science communication, and I'll talk about it in the context of South Africa during the COVID pandemic. I think the first thing, having worked on epidemics over the last 30 years in South Africa, measles and HIV and TB, COVID-19 set a new bar, and that bar was about public transparency, to the extent that every day the minister would release data on the number of cases, the number of tests, the number of deaths. There were regular media briefings. The president himself would go on television on a regular basis. It was called the family meetings, where he would take the public into his confidence and share the deliberations and the decisions of government. And all of this has come together to create a high level of transparency. And this was needed for COVID-19 because of the nature of the anxiety and the measures that were taken. But with all of that has come some of the challenges, and the challenges for us as scientists giving advice to our governments. And one of the big challenges is about dealing with uncertainty, particularly early in the pandemic, where everything was up for grabs because we knew so little. And so having to provide advice with lots of the ifs and the buts, and how that gets translated eventually into public communication is very different. And often what we had, even among scientists, is where personal opinion and speculation masquerades as science. And we've seen that in various ways, and not least in social media. And in this cartoon from one of our satirists in South Africa shows how the PhDs from WhatsApp and the master's degree from Facebook and so on, all of these individuals have opinions that they put forward, whether they're conspiracy theories or whether they are the know-it-alls, is part of the hazards we have to deal with in the communication. And often we're dealing with a complex situation about giving advice, and have to be careful that we're not posturing, that we're not making our personal preferences, but we're staying true to the evidence. And that's part of the big challenge of dealing with the high uncertainty. And one of those challenges and one of those consequences is that truthfulness became a pandemic casualty. In this particular instance, one of the major scientists in South Africa was quoted as saying that, this professor believes that 40 to 45% of the population has already contracted the virus, leading to the threshold required for herd immunity. And this was in July of 2020, just as we had passed our first, in October 2020, just after we had passed our first wave. Of course, it was just simply not true. But you've seen many ways in which falsehoods are being communicated, including by prominent scientists, and particularly claiming that COVID-19 is nothing worse than the flu. And there's a big group in South Africa, including actuaries and medical doctors, who have been arguing this, that why are we taking all of these precautions? Why don't we just let the virus spread? And of course, it's been commonplace in most countries. But in dealing with communicating science, we have to be very careful that we don't get involved in the blame game. I mean, within science, we accept that there are legitimate disagreements. And in science, we also call a spade a spade. We're not hesitant to do that. But we have to be careful that we minimize blame, because this is not about finding weaknesses in others and poking into that. That's a political process. And there, when you do that, when you start blaming others, you create disharmony and you break the social cohesion we need to work together, because we're dealing with a pandemic. And a pandemic, in the nature of COVID-19, is that we are all fundamentally dependent on each other. My risk is influenced by your risk, and your risk is influenced by everybody else's risk. So our interdependence becomes important, and we need to ensure that we continue to try and build on that social cohesion. I want to end off with, for me, one of the things that has been most striking, and that is that despite all of the challenges in communicating science, science has really been empowering. And I've seen almost a democratization of science through its increased accessibility. That science is no longer things that are done in ivory towers. The language and idiom of epidemiology and public health is now in everyday discussions. I mean, I have, individuals who are not even in the medical field, even youngsters in high school, writing to me and talking to me about R0. It's that everybody is now trying to grapple with what we are doing in science. And scientific evidence empowers people to understand the virus, how to prevent it, and enables them to make rational choices. But for me, one of the most important things is that ensuring that this information is getting out there is the bulwark against the conspiracy theories, the fake news, and the fear-mongers. That when people know what the facts are, they are in a better position to act. Thank you very much.
Thank you for pointing out the importance of communication in this context. We will continue with Petter Brodin from the UK.
Right.
But he's talking about Sweden.
Yes, so during the pandemic, I've been in Sweden. I am originally from Sweden, and I still have a joint appointment both at the Karolinska Institute and at the Imperial College London. But during the whole pandemic, I've been working as a pediatrician and a researcher in Sweden. So my perspective would be sort of complementing the previous speakers here by giving a sort of point of view from someone at the front line in terms of a physician seeing patients and trying to grapple with all of these new disease presentations, and also as a scientist trying to communicate with the public but also treating my patients, and sort of some reflections from my horizon in that respect. So my role during the pandemic has been, I've had one official assignment as an advisor to the Swedish vaccine coordinator, but other than that, I've had no influence in sort of Swedish policy making and Swedish decisions around how to manage the pandemic, which I think is important because it's been such a contentious issue, not only in Sweden, but all over the world, in how to deal with this new threat. What I have been very actively doing, though, is to communicate through media and this sort of informing the public in various ways, particularly related to children, which is my specialty. And what I've spent most of my time doing during this pandemic has been to see these patients appearing, from the beginning of the pandemic, we had no clue what this infection would lead to in our populations, which were children. And, during the first months of the spring in 2020, we started seeing these new presentations, such as this case of hyperinflammatory syndrome, where we really needed to kind of step up and work really hard to try to save these kids because they were very, very sick. They were also very rare, fortunately, and in the public sort of discourse, children were not severely affected by COVID, which is true, in a population sense, but that was not true for the families that I was seeing, that were in the intensive care unit, and a few hundred kids actually died, not in Sweden, but across the world. So I think this has been a really interesting experience to be sort of these discrepancies between the public discourse and the actual reality, which is variable. Another thing that I think is phenomenal about, and something that I will sort of be very grateful for have been a part of during this pandemic, is this massive global collaboration among scientists, among doctors, but also among other people, just sharing information like Salim just mentioned, which I think has been incredible. And I've been a member of this phenomenal collaborative network called COVID Human Genetic Effort, which is really, to my knowledge, unprecedented, where scientists from all over the world decided to share their data, share their experiences, openly discuss their hypotheses, and share them amongst each other in order to advance science more quickly, which is something that I think is contrary to what we typically do as scientists, where we keep the cards close to our chest and we don't want to share our secrets and so on. And it's been phenomenal. We've learned so much in such a short amount of time that I think this is something we should also bring forward and think about as we move forward to tackle other health challenges and crises and so on. So one of the things that going into the pandemic, we started seeing the virus spread. We knew that old people, quite early on, we realized children were not severely affected by the acute infection, but mostly the elderly and frail individuals were. But then we started seeing these new conditions like MIS-C. We started seeing rare cases of severe disease in young children, and realizing that probably reflects some underlying immunodeficiency that we should be understanding better. More recently, obviously, these persistent symptoms with long COVID, is popularly named, is a huge challenge for us. And so, as physicians and scientists, I think it's really interesting to think about how going into this with open eyes and sort of collaborating to try to tackle these new challenges. I must say, having been in Sweden over the course of this pandemic has been somewhat of a surreal experience in sometimes. For many of you, you probably know and follow the media reports in spring of 2020 and summer of 2020, when Sweden was considered to be the outlier, taking a completely different approach to the pandemic than any other country. And me and my sort of family members and colleagues were often wondering, are we talking about the same country of Sweden, really? Is it really the same sort of discussion? Are we in sort of parallel universes here? Because obviously nothing is ever black and white in that respect. It's always much more nuances. Obviously, one of the things that was very striking, and I think relates to the culture that we heard about earlier in the course of Netherlands. We have a similar thing in Sweden where I think there has been a cultural sort of backdrop to the way that decisions were made. One of which is a trust in governments, which has been sort of foundational in Swedish society. I think that has probably changed quite a bit through the pandemic. Another thing is that having a sort of informing the public and allowing the public to take their own decisions rather than enforcing rules and regulations on the public has been a sort of a tradition in Swedish public life that I think has been one of the reasons for the decisions that were made during the pandemic. And as you can imagine, being in a society, there are differences in opinions. Some individuals love Anders Tegnell here, who is this public health figure who was sort of the face of the management early on. And people make beers of him to celebrate him for keeping schools open, for allowing people to make their own choices. And then obviously on the other hand, he currently lives under constant death threats and police surveillance and unable to move about freely. And so you can imagine the discourse has been complicated. So again, from a physician-scientist living through this pretty crazy couple of years, one of the things that I've thought a lot about, and which I hope we can get into in the discussion here as we look forward, is how do we build resilience? And one of the things that I think has been really critical is to make sure that we foster scientific, academic environments, because science will be the one thing that takes us, any crisis, whether it's climate change or pandemics. And so to foster really strong clinical, also academic environments, and in my case, environments where clinicians are trained scientists, are able to assess scientific results and data and inform decision makers and the public based on science and not just prior beliefs. Because I've seen a sort of couple of decades of decreasing numbers of physicians training as scientists, and I think that puts us in a much worse situation for the next pandemic unless we turn that development around. And it's a global phenomenon, it's not just a Swedish phenomenon. So thank you very much. I'm happy to join in discussion later on.
Thank you very much, Peter. Very nice talk also about the outlook for the future. We will continue with a presentation by Mark van Ranst about Belgium.
Thank you very much. Also in Belgium we had different waves. We're now in the seventh wave of this pandemic. The upper part of the slide is the number of coronavirus cases, and the lower panel is the number of daily deaths. In our laboratory we do the genotyping of the viruses, and then of course we see all the different subtypes of the coronavirus popping up. We're now in the seventh wave with the Omicron BA.5 virus confronted. Our numbers in terms of hospitalizations per day, new hospitalizations per day, are again going up in this seventh wave, but are not reaching the level of the first and second waves. These are the number of intensive care beds that are occupied, and there you can see a clear difference between the first waves, 1 and 2 with the original virus, 3 with the Alpha, 4 with Delta, and then 5, 6, and 7 with different Omicron viruses. And it seems as if, in terms of intensive care beds, this is a situation that is improving. In Belgium, we have 17 intensive care beds per 100,000. Jaap has already alluded to it. In Italy, it's 8.6. In the Netherlands, it's 6.7. In Germany, it's 34. That means if these differences are so large, this will translate in different approaches on how you deal with it. In terms of mortality, this is the mortality curve. You can see that in orange, that's the deaths because of COVID. There was severe overmortality, but then after that, the overmortality has not been striking. Yes, you can see every wave, and yes, in every wave, people are dying because of COVID, but it's not reaching the level that was reached in the first and second waves. Our vaccination rate has been actually very good. That was not surprising because with normal childhood vaccinations we're doing fine too. About 80% has at least got one shot. Big differences between Flanders, Brussels, and the Walloon region. For example, in Flanders, of the over 65, more than 95% have been receiving at least 3 shots. But there has been trouble, and there were many differences, and I would like to highlight some. First of all, we have too many ministers of health. We're a small country, 11.7 million people, but we have 8 ministers of health. 8. Yeah? They don't even know, and I said that jokingly in the press, they don't even know each other's names right after the election, and that was true. So the press tried, and they couldn't name all 8 of them. Fake news was everywhere a problem, much the same as everywhere. That was true in Belgium too. COVID-19 might be a biological weapon created in US laboratories in Ukraine. That's then transmitted by the China Global Television Network. So a lot of trouble is going on there. Then what I really hate are the Captain Hindsights. The Captain Hindsights, they only appear after the war, and they're here to tell you what you should have done. So when the virologists and the experts were in the trenches, they're tired and they're dirty, and then when the later stages of the pandemic are reached, there they are in their white coats, and they're going to tell you what you should have done. Then you also had rogue scientists. Well, scientists that people that were once a scientist didn't publish anything since 1995, and then suddenly they're the big gurus, and then they're considered as gurus by the public, and then they're going to hate you. Van Ranst is a pure psychopath, mass murderer. You should rather listen to what top vaccinologist Geert has to say about these vaccines. So utter nonsense, but it creates havoc. Even ex-rectors of our university participate in that. So Rick Torres, an ex-rector, he says, I'm doubting if Van Ranst is always saying the truth or telling the truth. Van Ranst is very radical and extreme, and they set the stage with things like this. Then you have the hobby virologists, they were already alluded to. They graduated as Internet Doctor of Medicine. They continued their education at the Dunning-Kruger University, never going beyond the first stage of little expertise but much confidence. And then you have the trolls. The trolls want to make your life miserable, and they do. I'm not going to read all of them, but each panel is one day of messages that I pick up, and I definitely do not pick up all of them, just basically bad-mouthing you in whatever way they can. Then you have the tribunal fetishists. They're the ones that want to see you in the Nuremberg 2.0. Yeah? Very, very convincing. And yes, yeah, you're on the list too. You're the number 10 there, together with Marion at number 8. Yeah, there we go. So, some people really mean it, that's the problem. Mark van Ranst is on the nomination list for decapitation at the upcoming Nuremberg 2.0 tribunal, and many messages in that way. Then you have the political weaponizing of the online landscape. That's a big problem. The extreme right party, this is their president in Flanders, or in Belgium. The balls of Van Ranst have a very sour aftertaste. This is the same guy, Van Grieken about Van Ranst, were you drunk? This is another member of parliament depicting me as a baby. This is another member of parliament of the extreme right-wing party depicting me as Stalin. And they have a lot of magazines, their own extreme right magazines. But there, if you do that every day, it reaches the population. Give me an hour with Van Ranst and it's game over. Van Ranst is a dangerous, arrogant idiot, and there are many of them. Here I'm depicting like a piece of shit, ready to go to the TV studios, and then when you talk about monkeypox, then you're becoming this. And this is going on every day. This is another one. Could we have avoided corona deaths with your picture, as if you're responsible for all corona deaths? And then they make jokes about your name, and that is every day. That's another one. Mark Van Ranst is about to explode. Van Ranst, that's a member of the European Parliament for the extreme right-wing party, the Vlaams Belang. Van Ranst is incompetent, unprofessional, and suited, and that's all day. And then they're intimidating the experts. This is a lawyer, president of one of the anti-vax movements, and they basically call for the death penalty for Belgian virologists. They have manifestations, about 2,000 people. They're asking you to resign. And they're carrying these posters in Brussels. They compare you to Hitler. They're going to complain to you